Welcome to our live stream, Breakthrough in Adolescent Sports. Thank you for joining us. My name is Ryan, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this live stream technology. At any time, you may adjust your audio using your computer volume settings. For closed captions, click the CC icon in the bottom right-hand corner of the video player. Select English to enable closed captions. The Q&A polling tab is where you will ask the presenter questions. You'll need to enter your first and last name to participate in polls or to ask a question. To ask a question, click in the text box and type your question. When finished, press the Enter key or click the paper airplane icon to send the question. All questions that you submit are only seen by today's presenter. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. We are joined today by our speaker, Dr. Anna Katsman. Dr. Katsman is a board-eligible pediatric orthopedic surgeon interested in adolescent sports injuries, scoliosis, trauma, and hip preservation. She practices at the Pediatric Orthopedic Center in Cedar Knolls and Springfield, New Jersey. She is trained in physeal-sparing surgical techniques that avoid injury to young athletes' growth plates to avoid disruption to their normal growth. At this time, I would like to turn the microphone over to our speaker, Dr. Anna Katsman, for opening remarks.
Hi, thank you, Ryan, for that introduction. And I am Anna Katsman. And as Ryan said, I'm a pediatric orthopedic surgeon here at the Pediatric Orthopedic Center. And today my presentation is on breakthroughs in adolescent sports. And while there are many topics that can be discussed, I want to focus on updates on treatment of first-time shoulder instability and ACL injuries in the young patient population. I think my slides are stuck. How do I move them forward?
Do you want to stop the share and then reshare it maybe?
Sure. Here we go. Okay. Sorry about that. So today we will review the epidemiology of youth sports, and we will discuss updates in conservative, surgical, and postoperative outcomes and considerations of shoulder instability and ACL reconstructions. We will also discuss complication and return to sports rates with these injuries. In 2019, just over 50% of youth between the ages of 6 to 17 reported participating in a team sport or taking sports lessons. Annually, more than 3.5 million of kids under 14 receive medical care for sports injuries, and 1 in 5 shoulder dislocations occur in patients who are younger than 20 years of age. And patients under 20 years of age are the largest emerging subset of patients who are undergoing ACL reconstructions. The same population has approximately 3.5 times higher rate of re-tears compared to the adults. And we know that the highest risk of sustaining a re-tear of the ACL is in the first 2 years after the initial injury. So what are some of the possible causes to explain these trends? We now see higher rates of participation and increase in the level of competition. There is more sports specialization at younger age and year-round training. But despite these increases, overall, we are seeing decline levels of fitness, and it is interesting to see what the effects of the COVID-19 pandemic will be on injury rates over the next few years, as new data and studies are published. The natural history of shoulder instability has been studied for a long time, and multiple studies have reported on recurrence rates, risk factors, and treatment algorithms. The most common cause of anterior shoulder dislocation is recurrent instability, which is associated with functional impairments and glenohumeral arthritis. Most common risk factors for recurrence are young age and male sex, with studies reporting rates over 77% in patients who are over 13 years of age. And even though 1 out of 5 dislocations occur in patients who are younger than 20 years of age, there are not many studies that looked at pre-adolescent and pediatric shoulder dislocation treatment outcomes, and especially the management of a first-time event. So what makes the glenohumeral joint so unstable? And first, the anatomy of the joint predisposes it to instability. As we know, the glenohumeral joint is a very mobile joint, and there is very little bony contact and significant reliance on soft tissue, and especially the labrum, for stability. And anterior instability is the most common, and this is what we'll focus on today. There's also posterior instability and multidirectional instability. So whenever we talk about pediatric and adolescent patients, we always have to remind ourselves that they are not just small adults, and there are significant physiological and anatomic differences between our young patients and adults. And for example, in younger patients, there is an increase in tissue laxity, and the bony constraints are not yet fully developed. And so this makes the joint even more mobile and less stable. In kids with open physes, the capsuloligamentus injuries are rare, and we see more physeal injuries, or actually stretching of the capsule rather than actual labral tears. And this pattern changes to a more adult pattern as the patients reach skeletal maturity. So historically, adolescent first-time dislocators have been treated conservatively, and conservative treatment generally consists of approximately a week of immobilization with a sling or an immobilizer, followed by gradual strengthening and range of motion exercises. And return to sports is generally allowed when the strength and range of motion are restored. And some athletes are able to return to sports as early as 7 to 10 days after sustaining an injury. But how successful has this treatment been? A retrospective review published by Yap in the Journal of Pediatric Orthopedics just last year looked at 41 patients with a mean age of just over 12 who were treated conservatively after a first-time dislocation. And they had a pretty long follow-up of 7.9 years. They noted approximately 43% recurrence, and 1 out of 5, which is 20% of their cohort, went on to have surgical treatments. And what they also noted was all redislocations occurred in patients who are over 12 years old, and most of the recurrences happened within the first 2 years. Other studies that looked at adolescents have reported recurrence rates of 50 to 85%, which is generally double the risk of the reported risk of the patients who are over 20 years of age. And one of the more recent publications by Giuseppe Longo in 2018, who performed a systematic review of 15 articles that looked at a cohort of 705 patients who were all under 18 years of age, noted a 71% risk of redislocation. We know that recurrent instability leads to more soft tissue and chondral damage, and also bony loss of both the glenoid and the humeral head. And outcomes are generally less favorable in patients who sustain multiple events, often leading to non-anatomic procedures such as remplissage and Latarjet. And we also see long-term implications, which are arthritic changes in the glenohumeral joint, and they are often noted in early adulthood. So what about athletes who sustain a mid-season dislocation? A cohort published in AJSM in 2019 looked at 129 athletes that were predominantly male and with a mean age of 16, and 78% of the cohort were actually contact athletes. In the cohort, 97 patients were treated non-operatively and 29% treated operatively. And in this study, the authors defined success as return to their index sport with being able to participate fully in a season. And they found that in the non-operative group, 85% had a successful outcome according to their definition. But interestingly, they reported that only 6% recurrence rate in the same or the next season, which is very low compared to the other studies who have rates over 70% reported. So obviously this points out that sometimes athletes choose not to return to the sport for other reasons than instability. Outcomes of operative treatment are better, but still not great. Castagna et al. In 2012 reported on 67 overhead athletes with a mean age of 16 who underwent arthroscopic Bankert repair with 5.5-year follow-up, where they noted 25% chance of recurrence and 81% were able to return to sport. They, however, did not find a correlation between number of instability events or time to surgery between their outcomes of being able to return to sport. And then in the same systemic review by Longo et al., where they were looking at over 700 patients, they noted a recurrence rate of 17% in the arthroscopically treated group compared to the 71% that they saw for the non-operatively treated group. And lastly, Dickens et al. In the AJSM in 2017 looked at 45 intercollegiate athletes and reported data on 39 of them. They noted that 4 out of 10 athletes who elected non-operative treatment returned to play without recurrence in the subsequent season, and 26 out of 29, or about 90% of athletes who were treated surgically, were able to return without any instability events. So what are some of the risk factors for recurrence in our young athletes? A study published in 2021 in arthroscopy retrospectively looked at 35 patient cohort with a 20% rate of recurrence 1 year after arthroscopic stabilization procedure, and they matched it to a separate cohort that was age and sex matched that had no recurrence. And what they noted that there were several risk factors which were glenoid retroversion, skeletal immaturity, and more than one prior instability event that predicted future recurrence. And they found that risk of recurrence after arthroscopic stabilization was increased 3 times in patients that had 2 of those risk factors, and 3 times that had all 4 of these risk factors. So conclusions, patients under 18 years of age have a high chance of recurrence, especially if they participate in overhead or contact sports. Individual definition of success, whether it is no instability or ability to return to sport and complete a season or 2. So treatment, therefore, must be tailored to whatever the goals of the patient are. And conservative treatment is more successful in skeletally immature patients and those that are generally under 13 to 14 years of age. Contact athletes have about 75% chance of recurrence with non-operative treatment, and 20% chance with operative treatment. So I think all the newer studies highlight that operative management of a first-time dislocation in these high-risk athletes will reduce the risk of recurrence. But unfortunately, this risk is still relatively high. All these outcomes that I talked about are looking at arthroscopic stabilization, which is what is the most commonly performed procedure. But there's also some contradicting data on whether open repairs have better outcomes in these patient populations. And there are also Latarjet procedures that are an option, but I don't think that a lot of surgeons are doing primary Latarjets, and really we don't have the numbers to assess the outcomes. So I think as more studies come out, we will have better data to guide our patients. And now moving on to discussing advances in the ACL treatments. So just a little bit of review. ACL is a ligament that is composed of two bundles that run from the lateral femoral condyle to the anterior medial plateau. It is important to remember that the ligament is intra-articular and is bathed in synovial fluid, and its main function is to limit the anterior translation and rotation of the tibia. So historically, mid-substance tears were thought to be rare, and most of the pediatric patients sustained tibial spine avulsion fractures, which are considered ACL tear equivalent in the younger population. There has been a 20% increase in the rate of mid-substance tears and 27% increase in the reconstruction between 2007 and 2011. So are we seeing this trend because we are just more aware of the injury and are looking for it, or is there really an increase in some of the causes are the same that we see for other types of injuries, which are younger athletes, the sports are becoming more demanding, and we see more competitive play. So what are some risk factors for sustaining an ACL tear? So some of the anatomic risk factors are increase in the Q angle or the quadriceps angle, which is the angle that is formed between two lines. One of the lines runs from the center of the patella to the anterior superior iliac spine, and another line from the center of patella to the tibial spine, which is already greater in females. Those patients that have a smaller intercondylar notch and ligamentous laxity, which unfortunately is also what we generally see in the female population. For those patients with an increase in the posterior slope of the tibia, and in those patients who have a smaller sized ACL. And also female athletes or females in general have a little different composition of the ACL, which is more lax, and also have estrogen receptors and receptors for relaxin, which is also only present in females. Recently, there has been interest in research in the timing of the ACL injuries around the menstrual cycle, and the use of birth control to determine if that can have a protective effect against ACL tears. However, the data is still fairly inconclusive, and practically, I'm not sure how using birth control would work as protection against ACL tears. So as far as some of the modifiable risk factors, and those factors generally are the ones that can be improved. An upright landing with decrease in the flexion of the hip and knee, internal hip rotation, as well as hip adduction, and dynamic valgus of the knee. There are numerous neuromuscular and proprioceptive training programs that have been developed and have shown to be very successful. One of those is prevention injury and enhanced performance. And a study that looked at over 5,000 female soccer players that participated in this program and noted greater than 78% decrease in the rate of the ACL injury in those athletes that completed the training. So as far as non-operative treatment, we know the natural history of non-operative treatment of pediatric ACL tear is poor and generally results in early arthritis, poor function with recurrent instability, and secondary chondral and meniscal injuries. Dr. Ganley in 2008 reported that there is a 4-time increase in meniscal and 11 times increase in lateral compartment chondral injuries. And if the athletes choose not to return to sports, they lose out on numerous benefits of sport participation, which include improved physical and mental health, better academic performance, decrease in recreational drug use, and improved self-esteem, just to name a few. So one of the biggest reasons why previously non-operative or delayed surgical treatment was recommended was due to the fear of damaging the open physes and subsequent deformity. With more advanced technique and instrumentation now, we know that as long as we choose appropriate surgical techniques, the risk of damage to the growth plates are very low. And as the surgical techniques continue to evolve, there have also been more advances with actual repair of the ACL. So as a brief review, reconstruction technique and choice of a graft is dictated by how much remaining growth potential there is. On average, females reach skeletal maturity around age 14 or 2 years after the onset of menses, and males reach skeletal maturity at around 16 years of age. So for patients with 1 or less year of growth remaining, adult type of reconstruction is used. Hybrid or partially transphyseal fixation, where the distal femoral physis is spared, is used, and this is used in patients that have 1 to 2 years of growth remaining. For patients that have 3 years of growth or more, we generally recommend sparing both of the physes. And for very young or very small patients, a non-anatomic type of reconstruction where we use ITB band, which does not have any risk of physeal violation. So there are 3 types of grafts available for harvest, which we can use to reconstruct our ACL, which are bone, patellar bone, quadricep tendon, and hamstring tendon. Previously used allograft has really not done well according to numerous studies, especially in the younger patient populations. And generally, if it is used in our younger athletes, it's usually for lower demand patients. So the first bone graft, bone patellar bone, has been the gold standard for a long time. However, this can only be used in patients with closed physes. So a lot of the times, our younger patients are not candidates for this type of reconstruction. So hamstring graft has been a very popular choice and has been used in approximately 64% of reconstructions in patients under 18 years of age. However, the graft tends to be smaller, and we know that grafts, which are smaller than 8 millimeters in diameter, are at increased rate of failure. So the graft needs to be folded over multiple times to achieve a desirable size. and unfortunately can be accidentally truncated during harvest. And multiple studies show that failure rates are 2 to 3 times higher compared to the VTB. And there's also reports of increased rates of meniscal repair failures in young female athletes. We have also learned that in cases where harvested graft ends up smaller diameter, augmentation with allograft does not improve the outcomes as was previously thought and practiced. And some studies have actually shown that the outcomes with this hybrid graft is actually worse. And so while quadriceps has been used for a long time, over the last few years, it has become a more and more popular choice. So there are a few recent studies that looked at outcomes of using quadriceps in a study out of Emory, where they looked at 1,000 patients who were younger than 20 years of age. They only had a 4.2 rate of failure. And another study that looked at 22 patients who were approximately 15 years that used quadriceps, they actually did not have any re-tears at their 2-year follow-up mark. So another advantage of using a quadriceps is as far as preoperative planning. A study out of CHOP last year reported that more than 84% of pediatric patients have a tendon of at least 8 millimeter diameter. And while 8 millimeters, the number derived from our research on hamstrings, we still use this number when talking about other soft tissue grafts. And in fact, they found that a thickness of 6.7 millimeters on sagittal MRI cuts is 94% sensitive for us to be able to harvest the 8 millimeter graft. And since this is harvested with a 10 millimeter blade, if there is a concern, then we can use a wider blade or harvest full thickness graft to really make sure that it is much bigger in diameter. And here we only have one strand, and we don't have to rely on stitching multiple strands together to achieve the correct diameter. And this is actually an illustration from the original publication, where we can see how easy it is to measure the thickness and length on the sagittal image. So what are the outcomes of all inside epiphyseal ACL reconstruction? Cordasco et al. Looked at 23 patients treated with this technique, and those patients had 3 to 6 years of remaining growth, and at their 2-year follow-up, they did not note any significant growth disturbances, and all of their patients were able to return to athletics. And then using the same cohort, a study of out of HSS reported on MRI findings at the same 2-year follow-up, and reported that there were no physeal compromises with all of their all inside epiphyseal reconstructions. And this is the technique that we use in the younger patients, where we spare both the femoral and the tibial physis. And finally, Wall et al. Reported on 17 patients who were between 8 and 15 years of age, and found that using this technique, the outcomes were similar to other techniques that are used in patients who are under 20 years of age. So repair of the ACL ligament has become more popular recently. And one of the bigger advantages, especially for the young patients, is that this type of technique avoids drilling tunnels or sockets altogether. However, the downside to this procedure is it is limited to patients with acute tears, and the tears have to be very proximal or very distal, with good tissue quality, and they cannot be used for mid-substance tears, which unfortunately is the more common pattern. But even more recently, another type of repair using a special bovine collagen implant called BEAR has been developed and is becoming more and more popular and attractive. So how are patients with primary repair of ACL doing? And a study by Dr. DeFelice out of HSS looked at 11 patients with proximal avulsions of the ACL. They had a 6-year follow-up, and they had 10 patients available for follow-up. All of their patients had full range of motion. 9 out of 10 had negative Lachman and pivot shift, and they had very good outcome scores as well. Another study looked at outcomes of 20 patients between 6 and 16 years of age, also with proximal ACL tears, who underwent primary ACL repair. This technique used an internal brace for extra augmentation that was removed at 3 months, and they also noted that there were no failures of the repair. They did not note any growth disturbances, and authors did not find any side-to-side difference when used with an accelerometer. However, another published study looked at a cohort with 22 patients that were treated with suture ligament augmentation and compared it to 157 patients with quadriceps autograft. Their patients were also young, between 7 and 18 years of age, and they did note significantly increased failure rate in the repair group, which was 48% versus just under 5% in the quadriceps reconstruction group. But they note that in the patients who did not sustain a re-rupture, the outcomes and rate of return to sports were equal. So there are, however, no randomized studies on repair versus reconstruction, and there's actually currently one study going on in Europe where they're going to compare hamstring autograft versus repair. So hopefully we'll get good data from that study. So as far as the BEAR implant, it's important to remember that the ACL ligament itself does not have properties to heal itself. And since it is entirely interarticular, the enzymes in the synovium continuously break down the clot that is formed, and a bridge between the two torn ends never actually forms. So this implant is made out of bovine type 1 collagen and works to protect the clot from the constant synovial degradation. It is replaced by native tissues around the 8-week mark. And here is actual illustration of how this works, where we can see in the first picture the ACL is torn. In the second picture, we see this implant that holds the two pieces together. And then by 8 weeks, the implant is resorbed and the ACL begins to form. So here are some images from their original publication where we could see a mid-substance ACL tear, and then at 3 month, 12-month, and 24-month follow-up MRIs, we can see regrowth of the ACL. And on the right, we see sagittal cuts of the MRI, where we see nice orientation of the ACL fibers, which is essentially identical to the uninjured site. So the first randomized clinical trial was performed on 100 patients between 13 and 35 years of age with acute mid-substance tears, and they compared the outcomes. The patients treated with a bear, with a cohort that was mostly treated with hamstring autograft. And what the authors found was that the patient-reported outcomes were non-inferior, and hamstring strength as well as AP laxity were actually better in the patient cohort with a bear at the 2-year follow-up. And then using the same cohort, another study concluded that patients undergoing the bear procedure had earlier resolution of symptoms and increased satisfaction about their knee function, as well as improved resolution of hamstring muscle strength throughout the 2-year period. And the two cohorts had similar return rates to sports at 2-year follow-up, and their revision rates were also not statistically different. But these two studies that I mentioned report on outcomes at 2 years, and they are on the same cohort, which is not that large. So it'll be interesting to see how this implant does over long term, and what studies looking at bigger cohorts show us. So as far as return to sports, Decker looked at 85 patients who were just under 14 years of age and followed them for approximately 4 years. They noted a 91% return to sport, and incidence of a second ACL injury was about 32%, and it was split between 19% of re-rupture and 13% chance of rupturing contralateral ACL. And what they also noted that earlier return, which was in their study under 1 year, is predictive of a second ACL injury, whether it's ipsilateral or contralateral. And then Jeffrey K. et al., they did a meta-analysis looking at over 1,100 ACL reconstructions in cohort where the average age was 14. They had a 6-year follow-up. They also noted a 92% return to sport, and 78% of the athletes were able to return to their previous level of activity. In their study, they noted a 27% chance of sustaining another ACL injury. And this was split pretty evenly between the ipsilateral and contralateral sides. And then one last topic I wanted to touch upon is that timing of return to sports, and this has recently been a hot debate also. We know that our young athletes are eager to get back to the game, but when is it actually safe? We know that most of the re-ruptures happen within the first 2 years, but it's obviously not realistic to hold kids out for that long. So despite their motivation, these athletes have been shown to have more difficulty in regaining strength, and only about 60% of them achieve 85% strength of the contralateral side at their 6-month post-op visits. And sometimes we only see about half of the cleared patients who achieve the desired 85 to 90% strength of the quadriceps. And so a few studies that looked at return to sports in the young athletes after ACL reconstruction, one published in 2017, found that an earlier return to sport is predictive of second ACL injury. In a study out of HSS that was actually published this year, they noted that ACL re-injury rate was reduced by 50% for each month return to sport was delayed until 9 months after their surgical procedure. And they noted that young athletes who returned to sport earlier than the 9th-month mark had a 7-fold higher incidence of a second ACL injury than those who returned to sport after 9 months. And the International Olympic Committee actually recommends that athletes hold out for at least 12 months from pivoting sports. So I think that despite all of our efforts with optimizing surgical techniques, we must be careful with our return to sport clearance. So in conclusion, young patients with ACL tears can successfully be treated with reconstruction with techniques and grafts selected based on their remaining growth potential. ACL repair is emerging to be a very successful technique, but we must select our patient population carefully. And despite successful surgical techniques, proper rehab is important. And it seems waiting at least 9 months post-operatively significantly lowers risk of ACL re-tears or even sustaining a contralateral tear. Okay, so that's the end of my talk, and I think we have some questions.
Yeah, hi. I'll put these in the chat as well. But the first question is, based on your clinical experience, what has been the cause of the majority of sports injuries in pediatric adolescent patients that you treat?
Great question. I think, it really depends on the kind of the timing. A lot of injuries that we see are seasonal. In younger patients, a lot of the injuries we actually see are overuse injuries, so especially in the young throwers with baseball, a lot of the elbow, shoulder pain. It frequently we see just because of the overuse, poor conditioning, muscle imbalance, ligamentous laxity, and a lot of the times kids don't stretch properly. A lot of patients that we saw, especially as I mentioned after COVID, that were so eager to get back to their pre-COVID activities, were just not as conditioned, and a lot of the injuries actually happen when the athlete is tired because the body loses its ability to kind of protect the joints. So I think, in younger patients, overuse injuries are probably one of the more common things that we see. So another question we have, how can sports injuries such as shoulder instability and ACL tears be prevented? I think as far as shoulder instability, it is very difficult because most of those injuries that we see happen in contact sports. So it's hard unless you choose not to participate in a high intensity sport. You probably can't change your age or physiologically your gender because those athletes tend to be at the higher risk. But I would say definitely, I think working out and conditioning is probably your best bet. But the younger you are and the more time you spend playing, whether it's in practice or in actual games, I think that raises your exposure, and it's probably harder to prevent that. As far as ACL, as I mentioned, there are a lot of neuromuscular and proprioceptive training, especially for girls. And so that's definitely something that we recommend to be implemented. And it's something, if done properly and consistently, I think it can significantly lower rates. It's been proven. What treatment is recommended in order to provide the pediatric adolescent patient with the best possible outcome and lower risk of re-injury in the future? Definitely proper rehab before you return to the sport. And I think it's important to be cleared both by your physical therapist and your treating physician. I think physical therapy is great. Stretching and keeping up with just overall fitness. I think weightlifting, adding weightlifting in even young kids, proprioceptive training. And it's also important not to just focus on the site of injury. So, for example, if you injured your left knee, you also have to work out your entire body, including your core, because that can help to prevent injuries in the future as well. You mentioned that most patients would like to return to their sport as soon as possible. What is the follow-up treatment and approximately how soon can these patients return to sports? So I think that really depends on the injury itself. As we talked about with ACL, tears that end up having surgical reconstruction, I think that the closer you can get them to 9 to 12 months, the safer it is. With shoulder injuries or with shoulder dislocations, if it is a mid-season dislocation and the patient really wants to kind of finish out the season and address the injury in the off season, I think as long as they regain their motion and strength and they don't have frank apprehension, a lot of the times they can go back in 10 to 14 days. But obviously, if they are still very uncomfortable, if they're weak, letting them go out and play is definitely going to put them at a higher risk for recurrent episodes. So I really think it just depends on their injury, their goals, and it's very important to counsel them properly on the risks of sustaining another injury, so they can make an informed decision with this information that you can provide. What are the important signs and symptoms of sport injuries that coaches, parents, athletic trainers, pediatricians should be aware of? And when is it time to see a specialist? So as far as acute injuries, generally, obviously, if there is like a gross deformity, you see a significant amount of swelling, especially around a knee joint, inability to weight bear. I think those types of injuries should definitely be evaluated as soon as possible. A lot of the times, if the injury is not as acute or dramatic, a period of rest, icing, and anti-inflammatory medications can be tried. I would say usually if the symptoms don't subside in about a week, and if the patient has been complaining of discomfort or worsening pain, it is also a good idea to have the injury evaluated, because generally for injuries that have been especially overuse injuries that have been present for longer time. It usually takes longer for the rehab. So if you can stop the exacerbating activities and get the patient back or get the patient into physical therapy, I think they will be able to get back into their activities sooner. What are some of the complications if these examples of sport injuries are not treated? So I think we talked about the complications of shoulder instability and ACL injuries, but with other, especially in the young patients with open growth plates, a lot of times you can start to see damage to the growth plate, and we see this with little league shoulder, little league elbow. So I think that definitely you can sustain damage to the growth plates in the younger patients, and also if symptoms have been going on for a while and you see sometimes swelling in the joints, that could be indicative of damage to the cartilage, known as osteochondral lesions. So the longer you wait, kind of the bigger those areas of damage can become, and it takes longer for the symptoms to subside. And sometimes those can also require operative management. So I think if the symptoms are persistent, especially if symptoms are getting worse with activity, I think if you try to take a break and then you do the anti-inflammatory treatment and it's not getting better, I don't think that patients should wait for a long time, but have them evaluated and treated. And personally, I'm a huge fan of physical therapy. And I think it's very, very helpful to speed up the recovery and prevent worsening of injuries. Okay, well, thank you for joining. And this concludes our webinar. Have a good night.
Right. On behalf of Atlantic Health System, Morristown Medical Hospital, Pediatric Orthopedics, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete this survey to receive credit for providing feedback and attending today's webinar. This concludes today's stream. Thank you and have a great day.